We are live.
Good evening, all, and a very good afternoon right across the globe. This is iFocus Online, episode 377, the 52nd in the Oculoplasty module. Today truly is an international masterclass by none other than Professor Geoff Rose. Today it is an honor as all of us celebrate today as the Rose Day, and indeed a matter of great privilege and lucky fortune to have Geoff Rose on today's lecture from the Moorfields Eye Hospital to speak to us on techniques in orbitotomy, part 1. He does not require any introduction, and we have learned a lot from most of his articles published in various journals. He received his education in Bachelor's of Science in Pharmacology in 1976, completed medical school in 79, his fellowship of Royal College of Surgeons in 85, and Royal College of Ophthalmologists in 88. He is a member of the Royal College of Physicians, consultant staff at the Moorfields Eye Hospital. He has also been the director of the Ednexel service and is now an honorary consultant to the hospital. He received the prestigious Lester Jones Anatomy Award from the ASOPRS and is also honorary fellow. He lectures widely and with great grit and determination, and presented various named lectures right across all the platforms available in ophthalmology and oculoplasty. He is a senior research fellow of the Biomedical Research Center at the Institute of Ophthalmology, London, and has been the past president of the ASOPRS and the British Ophthalmic Oculoplastic Society. Over to you, Professor, for today's lecture.
Thank you very much, Dr. Subhav. I'll try and share my screen properly now. Yes, we're still running. Sorry, just, yep, make that. And excuse me, we're nearly there, I think. And I'll just move various bits out of the way if that's all right. Yeah, and give you a proper pointer. Well, thank you very much for the introduction and this chance to talk to what is really a very impressive course. And I'd like to talk about surgical approaches to the orbit. And I'd just like to say, if you could avoid taking any pictures of clinical pictures, you're welcome to take shots of any diagrams and so on. Let's go back a wee bit into the sort of early days when George Bartish sort of described some of the earliest surgery. It's quite amusing to look at. He was basically wandered around the Dresden area and was known for cataract catching using a clean needle, which was quite progressive for the late 16th century. But he limited his practice. He was already specializing in ophthalmology and hernia repairs. I'm not quite certain how they joined up to each other. But his book from the late 16th century, 1583, shows quite a lot of periocular conditions and is really quite fascinating. And he described various techniques for extirpating tumors of the eye. And very unfortunate, this diagram, which is well known, it's probably some poor folk with thyroid eye disease having both eyes taken out. Their anesthesia was a bit interesting because it basically involved tying the patient down and making them suitably drunk. But tumors, as you know, of the orbit and conditions have been around a long time. So here are a couple of 18th century manuscripts, one from the First World War time showing things hadn't changed very much, and a couple of patients that I've seen over the years, another 100 years later. So going back to surgery, in the early days, most disease was regarded as the work of the devil, and the devil lived in the head. And if in doubt, you cut a hole to let the devil out, as shown in some of these skulls that are over 2,000 years old. And it's interesting that some of these patients did survive having holes cut in their head, shown by the development of new bone around the areas of trepanning. It was still around in this 14th century manuscript from about 1380, possibly drilling a hole in the head, hard to know. And trepanning was very, very popular. Here's a 17th century manuscript of what you should take when you go to sea. And as you see, the trepan for drilling holes in the skull was still very popular then. Well, what's the relevance of this? Well, it really is that until the 1970s, orbital surgery was very much regarded as either a neurosurgical or general surgical procedure. And that was largely due to the influence of Walter Dandy, a very well-known neurosurgeon, who's thought that all orbital surgery should be performed through the transcranial route because such surgery results in less morbidity than the commonly used orbital approach. But it's interesting when you look how he describes it, the results following the transcranial operative attack of orbital tumors. However, I think we should get it clear at this point, where orbital disease originates outside the orbit or transgresses the orbital wall, the patient is best managed by the neurosurgeon or the max-fax head and neck surgeon using the various broader approaches. But the orbital surgeon still has a very important role in monitoring orbital function and ophthalmic status. But now coming down more to the orbital approaches themselves, where are the lines of relaxed skin tension where we want to hide our approach as much as possible? Well, sometimes it can be a bit hard to tell where the lines of relaxed skin tension run. But if you actually go back to a lot of artists, like here Rembrandt and Dürer in the 16th century, if you look carefully, they actually have very good appreciation of the lines of relaxed skin tension and the aging face, and certainly a better idea in the 16th century than in this 20th century manuscript of the lines supposedly around the face. Obviously, this is a much more appropriate diagram of relevance to surgery. And so we can use many different approaches to get to these various areas. One thing worth recognizing is that you get a reduction in the area that you can see, and also a change in the angle of observation as you go ever deeper in the orbit, because you're limited, obviously, by your access incision. So that for superficial lesions, you'll have a relatively big field. For deep lesions, you'll have a much smaller field. And this is what I've termed the conoid view. And likewise, the angle of observation of a change within the orbit gets ever more oblique the deeper you move within the orbit because of this problem of the orbital entrance. So there are really 5 principal orbitotomies, which we'll run through. And then there are things like the lid split orbitotomy, transnasal or translid endoscopic approaches, and orbital exenteration. So let's run through a few of the approaches. The upper lid skin crease incision, which really gives you very good access right down to the apex of the orbit, and really over about 2/3 the depth, or you can operate on the orbital floor through the upper lid skin crease, although it's a bit of a way down and a bit of a long way to get there. And so, for example, a child with a small mass, you can isolate it very nicely through the upper lid skin crease, and within a couple of weeks of surgery, you have the incision healing extremely well with no residual effect. Again, larger masses causing a huge mass in the upper orbit, and these can be removed intact and heal extremely well, again within a couple of weeks of surgery. Another example of a large-ish dermoid cyst along the orbital roof with marked expansion of the roof, you can remove these masses intact through the upper lid skin crease incision. So excellent access to the upper 2/3 of the orbit. And various vascular malformations, as in this patient, you can be readily accessed rather than damaging the lid margin. I tend to use upper lid skin crease and bias it to the side nasally if you want to reach a medial mass, and laterally if you want to reach the lacrimal gland. And you can take out large intraconal masses in the upper part of the orbit through that approach. And note, we put the drain in through the brow hairs. Again, drainage of abscesses, try and use a native skin crease rather than something like the Lynch incision, because it leaves less in the way of a final incision. These incisions can heal extremely well. So here's actually a patient who's only 7 days after orbital exploration through an upper lid skin crease incision, and you'd be hard pressed to know which of the lids it was, but it is in fact this one. You can tell just from the red line. So you can get a very rapid rehabilitation. Moving on to the second group of approaches really are those through the lower lid swinging flap, which is the inverse of the upper lid skin crease. When I was young, we used to go through the skin crease or the lower lid skin crease itself, leaving an external incision, but that really is unnecessary. And you put the incision on the inside of the lid and really get the lower 2/3 of the orbit. And so here, for example, a patient here with hypoglobus and a mass extending, and it goes back into the inferior orbital fissure, the pterygopalatine fossa, and the lower lid swing here with the end of the lid disconnected from its attachment. You can get very good access to the mass with it excised intact. It's a sort of slightly over 3 centimeters in size, and the closure is ideal and heals extremely well. You can use the same approach for some really massive incisions. So this child was sent for exenteration because of this highly abnormal vascular malformation. Let's say she has more than 4 centimeters of exophthalmos. But in fact, using the lower lid approach, you could really get throughout most of the orbit and reduce the mass. And here's the child about 18 months later with 624 vision due to her amblyopia. And we're going to tidy up her lacrimal glands slightly more. So it's a very useful approach to lower lid skin crease. I used it a lot in the past, in the early 90s, for minimal incision decompression. Up till then, people were tending to use the bicoronal flap, but I found that you could do it really through the outer angle and the lower lid swing. And as you can see, get an excellent result. And here he is after surgery with the healed incision, gone back about 11 millimeters on each side. Another patient literally before surgery with gross proptosis and what I call the line of continuity, which makes them look highly abnormal, and the same patient at the end of surgery through the lower lid swinging flap gives excellent access to the lateral wall, medial wall, and the floor. Soon after, I started frequently using the lower lid swing because we didn't use it when I was training in the 80s and really in the 1980s. We didn't really use lower lid swing. I actually came to realize there are actually 2 variants of the lower lid swinging flap, and they have different indications. One I've termed the low lower lid swinging flap, and the other the high lower lid swinging flap. The low lower lid swinging flap is where you go low through the fornix, so that you're going straight through the retractors of the lower lid and the conjunctiva and into the extraconal fat space, where you can go into the extraconal or the intraconal space. And so it's useful when you're going for masses within the orbit itself. However, if you have a mass on the orbital floor or a fracture that you want to address, the last thing you want to do is actually go down through the lower lid swinging flap, because you enter orbital fat, which not only gets in your way, but also encourages adhesions to the orbital floor area, as in this patient who had been explored elsewhere, and the surgeons had put in an orbital floor implant, but you can see it is completely exposed due to the tissues sticking down the conjunctiva of both the globe and the lid sticking onto the implant. So you should not use the low variant when you want to work on the orbital floor. For orbital floor work, you want to use what I've termed the high variant, where you go in 1 millimeter below the lower border of the lower tarsus. That way you avoid the inferior marginal artery, and yet these tissues, the conjunctiva and the retractors and the septum, are stuck together, so that you go through and disconnect the lower lid at that point. And you can then keep in front of the orbital septum, as shown here, going down. So this is the intact orbital septum, keeping the fat out of the way, and then reach the inferior orbital margin and then go into the orbit. So here we've reached the inferior orbital margin and we're going in across the orbital floor. And it makes life very much easier in that you keep the fat well out the way and you don't disturb the lower fornix. So that's where you use the high variant when you're working on the orbital floor. Moving on from that, lateral canthotomy. What you find is that the lateral canthotomy, your first part of your lower lid swinging flap, often gives you enough access to the lateral half of the orbit, the optic nerve, masses along the lateral wall that you want to deal with, and you don't need to actually swing the flap.
Sunil ji, has the video paused?
Exactly, sir. I think he's lost the class. He's lost.
Okay.
You're muted, Dr. Rose. If you could just unmute yourself.
Yeah. Did you lose any of it, or because my internet dropped out for a second? But you okay? You've got enough.
Yes,
Probably last 1 minute of it we lost, sir.
Okay.
you're muted, Dr. Rose.
It said the host muted everyone, which is interesting.
Okay. Would you like to reshare your screen, sir?
Have you got my screen here?
Can you please reshare it once?
That's difficult because I can't get the menu. It's gone.
Okay.
I can't get my memory. Menu. We will try. Hold it.
So you can press the Alt button on next to the space bar. It should get you the toolbar. Are you on a Mac or a Windows, sir? I think it's frozen again.
Yeah.
Can we just contact him not via Zoom? Do we have his?
We'll do that in a minute.
Yes, sir. The screen is visible, sir.
Right. Unfortunately, it says my internet is unstable.
Yes, sir. It's actually unstable.
Okay, so we got the screen now.
Yes, sir.
Yes, sir.
Good. Right. Sorry about that.
No issues, sir.
The trouble of the internet. Okay, and so literally by dividing between the heads, you can get into the intraconal space below the lateral rectus and the inferior rectus and have very good access. And take biopsies from deep tissues. You can work on the optic nerve from the lateral canthotomy alone and excise the optic nerve if necessary without needing to swing the flap. And here's an example of a girl with a huge glioma and a totally blind eye that didn't respond to chemotherapy. And here she is about 5 months later, and you can see the incision heals extremely well. The great thing about the lateral canthotomy is that you never disconnect the lid from its two canthal tendons, the two halves of the canthal tendon. So the canthus cannot drift, and you just have to join these together.
I'm sorry for the interruption of this service. The internet is a little unstable. We'll just try to get the speaker online in a bit.
Ma'am, can we ask him to switch to another network or any closer to the Wi-Fi if possible?
Dr. Rose, unfortunately, we were losing you in between.
Yeah, that's right. Can you hear us now?
We can all hear you now.
Sir,
See the
sir,
image.
sir, one simple request. I mean, so one humble request. If you can just switch off your camera, then do the screen share. Probably it will reduce the bandwidth required.
Okay, yeah, we'll try that. Sounds good.
Thank you.
Yeah, thank you. Sorry about it falling out.
No problem.
Can you see the pictures now?
Not really, sir.
You'll have
Could you please
to
reshare
share.
them?
Yeah, I'll try again.
All right.
Sorry, I can't.
Can we have his PPT and then play?
So how do we get the share screen up?
You can just escape from your current window and
Yeah, sorry about this.
that's okay. One of us will get in touch with you, Dr. Rose, and we will get this back online.
We are just facing some technical difficulties. We'll be back in a few minutes. Are we good, Dr. Rose? Sir, you're muted. You need to unmute yourself, please.
Yeah.
Yes.
I'm almost there, I think. He
Yes.
says if I can share this, we'll have a go. Yeah, we're getting there slowly. Sorry about this.
It's okay. If you can just switch off your video also, probably we'll have a
Thank you
smooth
for
run.
reminding me. That's a good idea. Okay. Oh,
Mind if I switch it from here? If it's okay with you, sir? Can I?
yeah, change. Yeah, please. I can't get rid of this the bar at the bottom.
Yeah, you can continue, doctor.
Yeah, just hold it. There's hope yet. We're getting there, I think.
Yes, sir. Perfect.
All good, sir.
Thank you very much. Sorry about this. It's don't you love technology? And so the basically lateral orbitotomy, in the past we would have definitely swung bone out to deal with these sort of lesions, but now I found you almost never require it. You can get a good approach, adequate visualization through either an upper lid skin crease approach or lower lid swinging flap, but generally upper lid skin crease. But sometimes, you do have really gigantic pleomorphic adenomas, which you need to excise intact. And the problem with them is reaching the back end of the lesion, where the blood supply comes in. And you may not be able to do that without moving bone. But what I have found in recent years is that most pleomorphic adenomas can be removed through the upper lid skin crease incision. So here's the sort of technique that we've described, where you mobilize the gland completely and then go down either side on the periosteum and reach the back end of the gland and divide it. And then you flip it forwards by sort of delivering it up a malleable, and you can flip it outside the rim. The back of the lesion comes anteriorly and it's still connected at the palpebral lobe. And you then grip the lesion and transect between the orbital lobe and the palpebral lobe, leaving a frill of normal lacrimal gland along and getting the lesion out intact. However, we do still occasionally use lateral orbitotomy, we don't require it very often. And the old Stallard right incision used to go through the brow hairs, whereas now we tend to use a lateral half skin crease incision extended inferiorly slightly. And this is a sort of huge incision we used to use through the brow hairs. And you got definite thinning of the brow hairs in these patients. Whereas now with upper lid skin crease, it heals extremely well. It's patients about 4 weeks after surgery. All these marks will completely disappear, and it is a much better approach. So how do we do it? Well, as I say, lateral half skin crease incision, extended slightly inferiorly, expose the rim, raise the periosteum over the rim, and mobilize inside the orbit. So you've got bare bone with the frontal bone and the zygoma and the zygomaticofrontal suture. And then we do the incisions, parallel incisions at the top and the bottom, to give you a nice broad piece of bone mobilization. And then we drill a couple of holes either side of the saw cuts. So you have your holes, and then we break this outwards. And we don't take the bone out now, we just tend to swing it out. You mobilize the temporalis muscle from behind where you've broken it off, trim this bone down, and if necessary, use bone wax. And you really get a very good view of the lateral periosteum. Open that, do whatever is necessary in the orbit. And then, because you haven't taken the bone out, it's just been hinged outwards, we just swing it back in, and you then close that area or secure it with some 5-0 or 4-0 Vicryl soluble sutures. I have no financial interests in what you use, but you don't need bone plates and so on. It just swings back because it's held by temporalis. Close the periosteum over it if there is periosteum, close the deep layer here, and then just a running suture in the skin. You don't need any deep sutures in the rest of the skin crease. It's only lateral to the lateral canthus you need deep sutures, and it heals extremely well. The fifth useful one is obviously the transconjunctival medial orbitotomy. And if you want to go into the sinuses or the extraconal space, it's often easiest to go through the retrocaruncular incision. If you go through the caruncle, the transcaruncular, you often end up in the rather meaty posterior lacrimal fascia. It's much easier to hold the plica and just open the surface between the caruncle and the plica. Or if you want to go close to the globe or more intraconal, you may want to do a peritomy, and it gives you very good access, either for intraconal biopsies or else for masses along the medial wall and for decompression. And you can deliver some really quite large masses through the transconjunctival route. So here's a huge medial dermoid being delivered. It's about 3 centimeters or so. And so, as I say, if you want intraperiosteal, you go down and leave the periosteum of the medial wall intact and just go down through the fat to the intraconal or extraconal space. And you can use that for taking out various lesions, very straightforward. The extraperiosteal approach to the medial orbital wall is where you want to reach the sinuses, and there you disconnect the periosteum at the posterior lacrimal crest, the area where the posterior lacrimal fascia joins to the fascia of the fossa, the lacrimal sac fossa. And so you want to get into the extraperiosteal space outside it to do a decompression. And so here's a view in a left eye looking down. That's the anterior lacrimal crest. We've opened the periosteum behind it and using it to hold the fat out of the way. And it gives you really very good access for decompression. So that here's the patient before and after decompression, you get right back to the annulus quite nicely. And really, you can also decompress the orbital floor to increase the decompression for a thyroid optic neuropathy. And it's a very quick operation. So how to do it? Literally, I just use 2 sutures rather than the speculum to hold the lids apart. You lift the plica towards you and open between the caruncle and the plica, and you just head backwards at 45 degrees with the scissors closed, then open them, and it just spreads very nicely, that plane. Get a retractor to lift the lacrimal sac and the caruncle out the way, and a 16 millimeter malleable and you can just literally, your intraperiosteal at this time, but there you will see and feel the firm posterior lacrimal crest, which you can then jump into the extraperiosteal space and use the periosteum to lift the tissues away, and then do a decompression, because you're right down there on the lamina papyracea, and you can remove the whole of the medial wall and the floor and the junction between them. Worth knowing the Mercedes sign for that area. The Mercedes sign, basically, you need to know it when you're doing this approach. So you have the floor, the orbitomaxillary interface, which runs back obviously to the back of the maxilla. You have the orbitoethmoidal interface, the lamina papyracea, which in most races runs slightly further back than the back wall of the maxilla because of the horizontal palatine portion of the palatine bone. And then the third arm of the Mercedes sign is the maxilloethmoidal interface, which is the infromedial strut between the ethmoid complex and the maxilla. And to get a maximum decompression of 180 degrees at the apex of the orbit, you need to remove this right back to the annulus, this right back to the back of the maxilla, and this area, the back half of the strut, the infromedial strut between the two. And we take out the periosteum if it's tough. And closure is very easy, just 2 soluble sutures to hold the plica next to the caruncle. Last of all, the lid split orbitotomy, I almost never use it. I don't think it has any advantage over the skin crease, but you bias it to one side or the other. I haven't found it any great benefit, but here's an example where you split the lid from the margin perpendicularly. You can get into the intra and extraconal fat planes and remove a mass if necessary. And it heals up pretty well and doesn't tend to cause a problem. But again, I don't use it because I don't think it has any real advantage over the skin crease incision. Basically, endoscopic approaches. Now, thinking a little bit about them as we come towards the end of the talk, endoscopic approaches, really the real advantage of orbital endoscopy through an eyelid approach is that it gives you better illumination and magnification of what you're dealing with. And so just to show you an example of how it can be useful here in the patient, we're just showing so that you can know the Mercedes sign. So this is the orbitomaxillary, but a beautiful view. Here's the periosteum of the orbit with the inferior rectus prolapsing down, and you can see the back of the maxilla, the area where the strut has been removed. And we now take a quick look. Just again, it's the illumination. This is just illustrative of how good. So that's the inferior rectus, the medial wall. You can see here where we've done the ethmoidectomy back to the sphenoid, and this is a posterior ethmoidal air cell down here. And last of all, where we've removed the back of the strut. Again, the magnification and view are wonderful, and no question about it that it gives you an excellent view. This is the anterior part of the strut still intact. This is the posterior part that's been removed, and that's the center of the Mercedes sign. Maxilla, posterior ethmoidal air cell, posterior ethmoidal air cell, missing maxillary strut. So it just shows the illumination and magnification are very good from that point of view. Secondly, the endoscopic approaches to the orbit. The advantages of the transnasal orbital endoscopy are to reduce compression of the posterior structures if you're working on the orbital apex. If you go through the orbit, you have to push the normal tissues out the way. If you come in from the nasal side, then of course there is less compression. It also has advantages if you need to remove the posterior sinuses after somebody has removed the mid-ethmoids with an incomplete decompression. And also it's obviously draining infected fluids from subperiosteal abscesses, from ethmoiditis and so on. It's much better to drain through the nose. However, there really isn't a good logical reason for performing transnasal endoscopic decompression of the medial and inferior orbital floor, inferior orbit, because it's actually more readily and more rapidly performed through a retrocaruncular approach, as I showed you. And also you have the problem that when you do a transnasal approach to the orbit, you are actually damaging the lateral nasal structures and the epithelium of the lateral wall, in fact, to get to the ethmoids. And we know from studies of nasal airflow and nasal function that they never truly return to normal. And they take about a year to get to their optimum state. So in general, I think that inframedial decompression for optic neuropathy is so readily done through the retrocaruncular approach that the endoscopic approach is probably unnecessary. But having said that, it can be useful for removing masses from within the orbit when they're very far back. So this is a large schwannoma, and Dinesh Salva in Adelaide kindly let me have the picture. So in summary, what have we really learned? Upper lid skin crease incision to give us access to the upper 2/3 of the orbit, the lower lid swinging flap, again access to the lower 2/3 of the orbit. Remember, there are the two variants. The lower lid swinging flap going through the low conjunctiva to get inside the orbit, or the high variant lower lid swinging flap to reach the orbital floor, where you go down in front of the septum and avoid going into fat. The lateral canthotomy, where you don't need the swing, but if necessary, you can convert it from lateral canthotomy to a swing. The bone swinging lateral orbitotomy we use much less than we used to. We no longer take the bone out, we swing it outwards on temporalis flap, and you don't need to plate it back in, you just put it in with soluble sutures. And the medial transconjunctival orbitotomy, of which I mentioned there are two variants really. The intraconal approach, where you're working inside the orbit, and the intraperiosteal approach, where you're inside the orbit, and the extraperiosteal approach, where you want to do an ethmoidectomy and you have to jump from the intraperiosteal to the extraperiosteal space just behind the posterior lacrimal crest. And then, as I mentioned, the lid split orbitotomy. Thank you very much, everybody, and happy to take any questions. And thank you for listening. Sorry for the technical problems.
Thank you so much, Professor. We do have questions from the social media portals. With your kind permission, may I proceed with those questions?
Of course, please. I'll try and I'll start my video.
We would be happy to see you again, Dr. Rose.
I'll see you again on Friday, but hopefully without the video, it seemed to work better. Thank you, Mr. Zadiotech. Sorry, I don't know who's hidden behind Zadiotech.
Oh, yeah.
Thank you.
Yes. The first question for this session is, what precautions should be taken during an orbitotomy to avoid a post-operative blepharoptosis?
Ptosis.
Yeah.
Right. The answer to that one is come on Friday, because I deal with it entirely on the complications of orbitotomy on Friday. So they've just volunteered, whoever asked it, to come for the lecture on Friday. We don't want to overtax the brain. It's tea time almost here.
Very well.
No, I go into that in detail on Friday.
Okay. The next in line is, how do we decide for the length of the incision? Is there any particular gauge or a measure with respect to the tumor size?
Yeah, the answer is, I tend to bias, for example, the upper lid skin crease incision, either to the medial 2/3 or the lateral 2/3. So if I've got a mass that is in the supratemporal quadrant behind the lacrimal gland, for example, the dermoid that I showed that lies in the greater wing of the sphenoid behind the lacrimal gland, I'll do a lateral 2/3 upper lid skin crease incision. And you go there and you then mobilize the levator superior rectus complex, just mobilize it medially, and you'll get a pretty panoramic view of what's going on. If you need to extend the incision, feel free. That's the nice thing. You don't have to make it massive to start with, but just give yourself enough access. And they heal so well because it's such a natural line. As mentioned, when you close the upper lid skin crease incision, you do not need to put deep sutures anywhere medial to the outer canthus, because the only area where the upper lid skin crease incision runs across the lines of relaxed skin tension is if you have to extend it outwards. For example, for lateral orbitotomy, just give it an extra 8 to 10 millimeters heading downwards. There you're crossing the lines of relaxed skin tension. So you need to close that area with deep sutures. Medial to that, in the upper lid skin crease, it just falls together. So a running nylon suture is all it needs. You don't need deep sutures, and they heal extremely well. As I showed in the little picture of the lady, it was really, there a week after surgery, Mother Nature is just...
Absolutely. So what would be the ideal approach to address a tumor lying over the orbital apex?
That's $1 million question. And again, we go a wee bit into that problem on Friday, complications with visual loss. In general, if it is above the optic nerve, I will go in unless it's very lateral and down the apex, then you can use a lower lid swinging flap. But in general, if it's above the optic nerve, I'll come in from above and just shift the levator either medially or laterally to give you the access that you need. If it's inferior to the optic nerve, we know that the risk of visual loss is greater. And that loss isn't so much direct injury to the optic nerve. It's probably, as I'll show on Friday, it's probably vasospasm in response to manipulation of tissues around the area. And some people would say maybe the risk is less if you come for, say, a transnasal approach to a lesion medial to the nerve. I've, in general, for masses below the nerve, tended to use the lower lid swing, or if it's really small, a lateral orbitotomy. But you will always get some visual losses with the apex masses. And the real question is, should we be operating them at all? Or should we be considering other things like radiotherapy for cavernous hemangiomas? The honest answer to that one is, I don't know. I just know what my own results are like, which are reasonable, but not perfect. If only we could make them perfect. Overall, I get with massive vascular malformations that I've removed that are wrapped around the optic nerve, I get about a 10% visual loss. But I actually consent the patient by telling them it's 30% loss. And if they still want to go ahead, I think, okay, if it's only 10 rather than 30, nobody can argue with that. It's like having a £10 bargain rather than 30 pounds.
All right.
I don't know is the answer.
All right. So while performing a marginotomy for a better visualization, what are the instruments that we frequently use and how do we go about the marginotomy?
Yeah, thank you, Subhav. The only time I do marginotomy, I don't do combined. I leave the neurosurgeons to do the orbital roof where they have to take out the roof and dura and so on. And likewise, I don't do mid-face resections, which are really the principal sort of major areas of resection. They're just people who can do it far better than I'd ever do it. But for lateral orbitotomy, as I showed, really any oscillating saw, the key thing about it, if you look at some books, particularly illustrations in some books, they literally have done the osteotomies only about 1 centimeter or 1 centimeter and a tiny bit apart, and swinging out 1 centimeter of bone gives you hardly any more access. Really go quite broadly, at least 2 centimeters at the upper margin, well above the zygomaticofrontal suture, and at the lower margin. You've got to give yourself the room if you're going to do it, and keep them parallel. It makes it much easier to break the bone out. And then when you've broken the bone out, because it naturally fractures along the zygomatico-sphenoidal suture line, as you snap it back or laterally, then trim away that sphenoid so as to give you the depth at the bottom of the incision. It increases the size of your window. And it's nothing special about it. I tend to use a 2 millimeter burr for the drill holes, just literally to pass the suture backhanded through it, a bit of 4-0 Vicryl. And the actual osteotomy is just an oscillating, medium grade oscillating saw. We have a striker, but it could be any, there are many, many makes. Again, no financial interest in any of them, as long as they work. In the old days, it used to be a steam hammer when I was there. with pneumatic compressed gas and so on.
All right. Any particular tips for an en bloc excision biopsy in cases of adenoid cystic carcinoma of the lacrimal gland?
My view is that if the lacrimal gland mass is well defined and ovoid, there is a risk, it's highly likely that it'll be a pleomorphic adenoma, but some of them will have undergone malignant transformation to become malignant mixed, which are generally adenocarcinoma. But every so often, adenoid cystic carcinoma, which of course is a primary rather than a transformation within a pleo, adenoid cystic will be relatively well defined. And so in those cases, you will have come up to it, you will have treated it as though it's a pleo, because what I've found is where I've removed what could be a pleo with intact excision, less than 10% turn out not to be pleo. They'll either be extreme sclerosis of an inflammatory process or a malignant mixed tumor. And if you take them out intact, just as you would a pleo, the technique is the same. But with en bloc adenoid cystic, I don't mobilize bone, because we found the biggest problem we had in the early days with adenoid cystic was recurrence, where we removed the margin at the same time as the gland. You ended up entering the diploe, the marrow spaces at the edges of your osteotomy, and that actually seeded tumor into those spaces, which then grew like sort of well-fertilized garden. And it was absolutely horrible. These people would come back with these massive recurrences in their calvarium. And since stopping that technique in 1990, I have not seen another patient come back with intracalvarial recurrence. So I think we were actually seeding it where we did osteotomy. And nowadays, I just debulk, because you're not going to get all the tumor. Therefore, you're going to need either adjunctive chemotherapy, radiotherapy, or probably both. And I think probably both is the best long-term answer. But I now just remove the mass in the sense that you're removing 98, 99% macroscopically, and the rest has to be dealt with local radiotherapy and chemo probably. I think chemo will turn out to be the long-term answer, but we need a bit of long-term results on it, as to the best regime.
And in continuing to that, Professor, do you prefer giving a new adjuvant chemo prior to your surgical option, or you don't directly go in with the surgical option followed by radiation and then chemotherapy? What is your preferred approach?
Yeah, for adenoid cystic, I have no experience of preoperative chemo reduction. And, that may well be, again, we don't see some of the cases that people, like Santosh and Myelin see, just sort of, I have seen them in the past, but inevitably you get some really spectacularly far end of the distribution curve. And so we don't tend to use chemo reduction because we're reducing it with a red hot wire, if you see what I mean. So from the surgical point of view, it doesn't matter how big it is. We'll just literally take everything macroscopically out. But again, it depends on circumstances. Post-operatively, we use radiotherapy. I think external beam is probably better than brachytherapy. Brachytherapy is limiting its area to alongside the lacrimal, the fossa, whereas in fact the highest recurrence rates are more posteriorly in the area of the cavernous sinus, the inferior orbital fissure. And so we include those areas because of the risk of perineural spread. But still, the patients, a lot of our patients die, well, not a lot of them, luckily it's a minority now, die, but they die from systemic, pulmonary disease, which often appears within 6 months or a year. And I suspect they have the disease, and that's where chemo will almost certainly be beneficial. And, we keep watching with interest the long-term results from, people like David C. and Santosh and so on as a team. because that's, I'm sure, will be the answer for prolonging life. It may not cure them entirely, but it may at least delay the time they die.
All right, Professor. And how about suturing the periosteum? Do you suture it in all the cases, or?
Good question. With the lateral orbitotomy, with the medial decompression, you don't need to, because you want the fat to prolapse out, and so you don't need to do anything like that. With lateral orbitotomy, if you're going into the intraconal space to do something, then you'll still have the raised flap of periosteum, which you raised from the external surface, and then I just suture that back down to the anterior edge of the temporalis fascia. If, however, you are taking out a pleomorphic adenoma, you've lifted the periosteum forwards, you've then gone down inside the orbit in the extraperiosteal layer, so the periosteum goes away with the tumor, is taken away with the tumor. Therefore, you don't have that marginal periosteum. So in those cases, I just do the soluble suture to put the bone back in place. And you just ignore it. You just close the deep layers over it, and a pseudo-periosteum will form within a few days, well, a week or two. But we don't use lateral very much for pleos anymore, even big ones. As I say, I wrote up the paper there where we compared lateral outcome versus doing it without the lateral, and they actually do really well each way.
Professor, your experience with a cryo-assisted delivery of the tumor or orbital mass?
We haven't tended to use cryo. I know it well, but I think use whatever technique you find useful. With things like cavernous hemangiomas and so on, rather than cryo, which if the cryo machine sort of dies halfway through or the gas runs out, I tend to grip them with a broad pair of artery clips, just literally, and you can compress it and just gently control the mass by holding the artery clip. So, any way that works, I think, is the answer. If you learn with somebody, who's skilled in the use of cryo, then that's perfectly, I have no problem with that at all.
Mm-hmm. And is it like mandatory to leave a drain in all the cases of orbitotomy we perform, or is it?
I will talk more of that on Friday. Everything to do with why you put a drain and its importance in visual loss. The answer is wherever there may be problems with the optic nerve or serous or blood accumulation. But anterior ones, like, for example, lacrimal gland masses, I don't put in a drain. Again, with lower lid swinging flap, I don't tend to put a drain in unless it's an apex lesion. The reason being that the lower lid swinging flap, when I close it, I only put one conjunctival suture at the lateral end, to bring the conjunctiva up to the lower border. The medial end, of course, is fixed. And so there actually is a gap between the conjunctiva, between the conjunctiva and the lower lid. So fluid can escape that way. So in general, I will not put drains unless you're in the posterior third of the orbit.
And one of the videos which you just showed about the inferior strut being removed.
Yes, the back half of it, yeah.
Correct, yeah. I just wanted to know what is the extent of the removal of the inferior strut, and does it alter the mechanics of balance of the globe within the orbit?
Yeah, no, that's a very sensible question. The answer is in the early days, and I'm talking sort of like 35 years ago, I used to remove the whole of the infromedial strut. And then I had a whole series of patients who got secondary imploding antrum syndrome. They were great to start with, and then the eye would sink downwards over about 18 months due to glue antrum. And what was happening was the anterior fat was prolapsing antero-infromedially and blocking antral aeration.
Okay.
So now I only ever removed the posterior half of the strut, and the anterior half remains intact to keep the fat away from the antral opening.
And Professor, the difference in the approaches that we follow in different types of orbitotomy, when would you prefer a transseptal versus a transperiosteal approach?
Sorry, and what's that question? Because your transseptal in general, you can reach anywhere. As we mentioned, with the upper lid skin crease, you can reach the orbital apex. With the lower lid, you're actually sort of post-septal anyway. You know, if you do a lower lid swinging flap, you're already behind the septum. With the canthotomy, you are behind the septum already, and clearly lateral orbitotomy. But I don't tend to, you know, some people will try and go as far extra periosteally as possible and then go into the orbit. I rather like the sort of panoramic view, you know, where you're already in the orbit and can get things orientated. You're following your way back, for example, along the medial border of levator to get to a supranasal mass. You actually get a much more panoramic view from anteriorly rather than going in outside and then trying to hit the thing inside. But I could, you know, gain experience. People will be good at the other approaches.
For the transseptal approach, once the septum is open, there's obviously the fat prolapsing out. So
yes,
any particular tips to move the fat away for a better visualization of the orbit?
Yeah, no, absolutely. You've got it exactly. Basically, if you want to go to the supralateral quadrant, you move the preaponeurotic fat pad and levator and so on medially. If you want to go to a supromedial mass, you then, be it intraconal or extraconal, you move the fat and the levator laterally and so on. So you just move it, but keep it on its blood supply.
All right. And Professor, for a superior temporal mass in the orbit, or a mass in the superior temporal quadrant of the orbit, where what is the preferred approach? Whether do we use a upper lid crease incision, or do we go for a subbrow direct approach?
Yeah, no, I don't use the subbrow approach. I tend to leave a visible incision because it's on a convexity, so it's a bit like offering the incision on a plate for the patient. It's not hidden in the natural fold, and you can reach anywhere in the brow area, the orbit, and indeed I've removed a dermoid that extended from the temporal fossa into the pterygopalatine fossa through an extended upper lid skin crease incision, just running out on the line of relaxed skin tension by about another centimeter. You can just give it that extra bit of length. It's amazingly mobile, this sort of whole area. So you can literally move it around. And there is no reason to then actually do a subbrow incision, which is a bit prominent. It tends to be rather prominent, a bit like the Lynch-Howarth incision, you know, the supranasal quadrant. It's a bit like saying, hello there, have a look at my scar. You know, it's a nice, obvious one. It's all right if you want street cred, you know, to look as though you've been in a fight, but most people want it a wee bit hidden.
That's a very good point to sum it up. And before we conclude for this session, I have a small announcement to make. We meet next on the 9th of February for the second part of this lecture by Your Learn Itself.
Thank you, Dr. Rose. We had a very, very nice time listening to you. And it's like we've started a storybook and we really want to finish it on Friday. It's like we really don't want to stop, but we have.
Thanks very much, Mritika. Thank you. Thanks, everybody. Yeah, it's been great fun. And we'll see you, God willing, on Friday.
Yes. Look forward to it.